But
Okay.
we have a chair for you here. You can see. We don't want you to be too direct.
No, it's okay. We'll end up good friends. No worries. So this is the topic. And first of all, I would like to put it in the context of what has been achieved so far with TAVI. So we know that TAVI is better than optical medical treatment in patients that are defined as extreme risk for surgery or no option for surgery. And TAVI is at least equivalent, based on the partner study, the Cohort A, or even better based on the CoreValve, the high-risk patient, than surgical AVR in symptomatic AS patients at high risk for open heart surgery. There are multiple studies to support that in prime publication. These are the 4 partner publications in the New England Journal of Medicine. This is the CoreValve extreme risk publication in JACC. This is the CoreValve high-risk US pivotal trial that was published earlier this year in New England Journal of Medicine. And these are the inclusions and exclusion criteria of the trial: the partner B, the no surgical option patient, the partner A, the high-risk patient, and the CoreValve extreme risk patient, and the CoreValve high-risk patient. And I'm going to review in brief these studies and actually update, because what we have now are some of the longer-term data. This is the partner extreme risk patient, the 5 years follow-up. The group in yellow is the optical medical management. The group in blue, light blue, is the TAVI group, and you see that over time now we have the extended follow-up up to 5 years. Almost all the patients in the optical medical management died, and 70% of the patients actually died in TAVI. But again, this is a very profound impact of TAVI compared to medical management. Now, in the CoreValve extreme risk group, we have in this trial, it was unethical to set up a control group of optical medical management. So the trial set a performance goal, so it's kind of a virtual control. And you see here that again, against the virtual control, the group that was treated using the CoreValve and had no surgical option had much better outcome compared to the virtual or the performance goal. It was 38% mortality over a period of 2 years compared to the performance goal, which was 58%. What about TAVI versus surgery, surgical AVR in the high-risk patients? So we have now the 3 years follow-up in the partner Cohort A trial. And you see there is an initial advantage of the TAVI, but over a period of 1 year, 2 years, and 3 years, the mortality actually is identical. In 3 years, 44% in both groups died. On the opposite side of the story is the 55% of the patient actually survived. I think the highlight of the TAVI field has been derived from the CoreValve high-risk patient. These are the 1 year results that actually showed a prognostic advantage or survival advantage for TAVI in yellow versus surgical AVR in blue. At 1 year, the mortality was 90.1% for surgical AVR versus 14.2% for the TAVI group. And actually, we now have the extension of the data over a period of 2 years, and the results are sustainable. And this trial actually met both endpoints in terms of non-inferiority and superiority, and when it was examined as treated and by the intention to treat analysis. Now, the question that I was asked to discuss is not necessarily about the extreme or high risk patient. The question was about the moderate risk patient, and in reality, low risk patient, lower than the extreme and the high risk, low risk patients with symptomatic AS are being treated already. This is the reality in most parts of the world and including in Israel. And how do I know that? I know that because there are already multiple publications in EU. You can see several publications in very good journals that actually describe the outcome of moderate risk patients that are being treated using TAVR. And if you perform a survey of the TAVI Registries in different countries across Europe, you see that a significant portion of these patients are at logistic EuroSCORE that are way below the cutoff of 20 or even 15 or even 10. So a significant proportion of patients could be defined according to these criteria, the risk score criteria, as moderate or even low risk patient. Even if you explore some of the most contemporary trials, you see a very clear trend that the partner started with STS score of 11, and now we're talking about the TAVI Registries, the US registry. The mean STS score is 7%, and even in the high-risk patient, we are talking about the partner A, which started by almost 12. The CoreValve high risk was 7.3%, the STS score, and the TAVI registry, the high-risk patients are already at the mean of STS of 5. So the reality is that in most parts of the world, including Europe, US, and I'm confident that this is the case in Israel, moderate risk patients are already treated. Now let's zoom into the CoreValve trial. In the CoreValve trial, which was defined as high-risk patients study, actually a lot of patients, a significant proportion of patients were with a STS score less than 7%. And you see here there is no interaction between the results obtained, between the advantage of TAVI versus surgical AVR obtained in patients which were either at STS score of less than 7% versus patients that are more than 7%. So the impact of TAVI could be obtained among patients which are at moderate risk. Now let's look at the mortality cause among TAVI patients. Now when we are talking about extreme risk patients, and this is the presentation that was just made during DCT, you see that here, that for the TAVR patients, almost half of these patients actually died due to non-cardiovascular causes. So the major hurdle of TAVI, or the TAVI among high-risk or extreme risk patients, is the fact that these patients have so many comorbidities. So if you can get rid of this comorbidity by defining more easier patient or moderate risk patient, you may actually improve the results of TAVI, theoretically. Now, if you look at the partner A and you again explore the impact of the STS score on mortality, so again you see the advantage of treating patients at the STS score of between 0 and 11 rather than patients at more than 11. So the mortality is much less compared to higher risk patients. And again, similar trends you see here in the CoreValve high risk patient, the 2 years mortality, the all-cause mortality is 36%, the cardiovascular mortality is 26%. So 10% increment in mortality is due to non-cardiovascular causes, due to comorbidity, due to the reason that the STS and the logistic EuroSCORE are much higher. Now, there are retrospective analyses from multiple trials and registries across Europe to indicate that low-risk patients are actually being treated, and the results are very good. If you take the Bern and Munich experience and you distinguish between low-risk patient and high-risk patient, you actually see that the mortality among the low-risk patient is very, very low, in the range of 3 to 4%, compared to the high-risk patient, which is around 11 to 14%. And again, this is a match propensity study that actually compared patients as moderate or even low-risk patients and compare surgical AVR versus TAVI, and you see the mortality is very different at 30 days, 7, 4%, and 2% in this analysis. So there are data already to support the consideration of TAVI. I'll be very cautious in what I'm saying here. The consideration of TAVI among moderate risk patients, and moderate patients are those that are at elderly patients with less comorbidity that we used to treat before. Now you have to appreciate that TAVI has evolved and improved dramatically over the years. We are talking nowadays about low profile systems between 14 and 18 French, low need for alternative access, improved procedural outcomes. Now the procedural success now is approaching 97, 98%. A low risk of stroke events, which used to be around 5, 6%. Now we are talking about 2%. Low risk of paravalvular leak with better imaging, valve sizing, and emerging technology. But paravalvular leak is certainly the Achilles heel, to my understanding, of contemporary TAVI. No need for general anesthesia in most cases. Shortened procedural time between 30 and 60 minutes. Shortened recovery and hospitalization course, and some new program which are aimed at next day discharge. New devices, new technologies addressing prior hurdles, and excellent durability, and data now are available for up to 7 years. This is the SAPIEN 3, the new generation of SAPIEN, the first in human, actually demonstrated outstanding result with very, very low rate of paravalvular leak. This is the new Evolut R recapturable and repositionable and resheathable system by Medtronic, and I'm going to specify this system later on. This is the LOTUS TAVR system with the REPRISE 2 study, again specifically designed to minimize the potential for paravalvular leak, and additional systems are truly designed to address some of the major issues that we have had so far using TAVI. Now let's talk about, I have a missing slide here. I have a missing slide which is important. Can you check please what's going on? Let's talk about the 80 years old lady. The 80 years old lady with the area with the improved device, preferential for percutaneous transfemoral access, reduced use of general anesthesia, less intraprocedural TE, we eliminate the pre-dilatation, we decrease the use of complex and costly hybrid cath labs, early ambulation, and fulfilling the patient expectation. This strategy should become the AVR default in many of the elderly. Now, we need, in order to implement such a strategy, I believe that we need to implement the concept of TAVI Center of Excellence. This cannot be a risk. This should be a very predictable procedure. I think that if a team or a center is aiming to replace surgical AVR in the low-risk population of AS patient, it needs to fulfill the following objective criteria of TAVI Center of Excellence, and these are my criteria. These are not guidelines, okay? TAVI volume, I think, should be at least 50 cases per year, per center. There should be a multidisciplinary heart team in place, including a surgeon, no question about it. It should be predictable, favorable procedural outcome, mastering the most advanced TAVI equipment, strict monitoring of quality measures defined by the VAR 2, minimizing paravalvular leaks and eliminate moderate residual MR, master peripheral vascular techniques, dedicated screening facilities, highly trained TAVI teams, dedicated TAVI follow-up clinic, and effective communication with referring doctors and nurses. So in conclusion, ladies and gentlemen, TAVI has evolved into a predictable and doable procedure in extreme and highly symptomatic AS patients. Contemporary EU series and ongoing trials already treat moderate risk AS patients using the TAVI technique. Robust and extensive data are needed to establish TAVI as the default treatment in moderate or even low symptomatic AS patients with suitable anatomy and vascular access. Centers of excellence for AS management should be established by multidisciplinary heart teams that work together according to best medical practices for the benefit of patients and by considering patient expectations and wishes. Thank you very much.